But I do feel really privileged to have worked on so many great initiatives throughout my experience. And OASAS is, I started working on OASAS's budget at the Division of Budget. So this is like full circle for me. And this work here in the Restructuring Addiction Services Funding Project is all encompassing, and it kind of brings home a lot of different elements that I have worked on in the past and look forward to working on in the future. So without further ado, let's get this started. Okay, so just a brief little agenda of how this presentation is set up. I'm going to do a little review of the project just to level set. And then I'll discuss how it's broken into different cycles, phases. I'll discuss the amount of work that's been done with community input. Also reflect on and review for you the enormous amount of data that has been looked at and will continue. And then what are the next steps with this project? Okay, project review. So just to talk about, I know that you all know, but I'm just going to say, it's net deficit financing, right? We're looking to redo how we provide state aid, and right now in the state, per statute, we provide funding through net deficit financing. So what is that? That's your approved operating expenses minus all revenues equals your net operating, budget. So if for some reason you're awarded state aid money and you don't have enough expenses to put towards that state aid amount, we take it back. If you do have enough expenses, but you then also have more revenues, we take it back. Right? So, boy, that statement just sounds terrible. So, okay, so feels really good. Yeah, so let's talk about though we can't throw the baby out with the bathwater, right? So there are some advantages. So they are, supports uncompensated and underfunded care, subsidizes costs not adequately reimbursed, and provides funding for services not traditionally able to generate insurance revenues, right? Those non-clinical community providers, etc., right? And let's not forget, and this is really a big one for us to be able to continue to do in a new funding mechanism, and that is we advance funding. We're the only state that does that, especially with the substance use block grant, okay? So this is a very cool thing. I also want to say that New York State provides the most funding than any other state in the United States. So we get a block grant that's anywhere from $110 million to $120 million, depending on the formula for that given year. But we provide $500 million every year. The closest state to us is California, and they're almost 400 million, but their block grant is 200 million, right? We provide an amount of money that shows our dedication to this field. It could always be more, right? But we do support this continuum of care. So those are the advantages. Okay, so what are some of the disadvantages of this funding? Well, we have historical budgets that don't provide equitable or consistent reimbursements for the same services, even in the same geographic area. So you all know probably better than I do, right, that some of these budgets are from the 70s, the 80s, the 90s, etc. Cost of living adjustments certainly are applied to those base budgets, right? But if, for any other needs, you have the state aid ask process, but the budgets for those historical budgets were never rebased. So if you open a new service, it started at a higher amount of money because that is rebased, right? So that's inequitable, but also you could even as the same provider, provide, an outpatient service on one side of, Albany County, and then on the other side, and I guess it's just completely different budgets, right? And so we're interested in taking a look at that and making that more standardized, right? There's no fiscal incentive for administrative or program efficiencies. That doesn't mean you don't make them. It just means that it's not incentivized by the money. And then it can be inconsistent, right? Because if you start earning more revenues over a certain amount of years, then we will eventually take it down. But if you have more losses, you'll eventually go up. There's little shifts, but so Those are the disadvantages. So what OASAS did, and actually it's the executive and the legislature put in the statute into our appropriations that we would embark on, taking a look at different funding mechanisms to replace net deficit financing. We realize at OASAS, we are the experts. Like, there's no one better at doing net deficit financing. But that doesn't help you if you want to look at different funding mechanisms. So we really needed an outside entity that would be, objective, experienced, knowledgeable. So we put out a competitive procurement, and after, reviewing and interviewing, we awarded that to provide a vendor, Third Horizon Strategies. Here on in, I'll refer to them as THS, okay? Because we love our acronyms. And so anyway, and what Third Horizon Strategy is, they're a very experienced organization, and they are assigned to research and develop an updated and equitable funding mechanism approach that may be different for many different programs that we fund. The process is that they are, they've put out surveys, they're engaging with focus groups, they're collecting data, they've done internal reviews within the OASAS organization. We are also providing, status update calls, presentations, town halls, getting to present to you all here at the inaugural InUnity conference, and we are seeking feedback and involvement. The resources that we have, as you can see, are updates, and this is being taped as well and will be posted on our website as an update for where we are, a status update on this project. And we do refer to as RASFP, which I want to break into song and say RESPECT. But, the timeline for this project, and there's also a mailbox to send questions. The timeline is that the research and development of the financial model is conducted into a phased approach. Right now, our engagement, the contract is for 5 years. And the product is, the goal, right, is to develop a modern and equitable financial model that will be sustainable for providers and will yield improved delivery service. So what does this phased approach look like? Okay, so let's just say if you follow the first, I get to use my laser pointer. Ooh, okay. So there's multiple things going on here. I'm just, multitasking. All right, so if you take a look at the cycle itself, we're saying, cycle research, there's 3 cycles. And they are differentiated by the services that are being reviewed in that cycle. We start off with doing specific research functions with the consultant. Then the consultant is collaborating with stakeholders. Then there's an analysis of the current system, and the financing reimbursements. But as you go into other cycles, it's specific to that cycle, looking at current state, looking at, SWOT analysis, strengths, weaknesses, opportunities, threats. Then looking at developing what could potentially be a new system of financing and reimbursements. And then, implementation and process. And implementation, this is where the rubber meets the road, but it's also iterative in its own right, meaning that we need to look at what are our data collection systems, what is the reporting, what types of materials would be needed to use for training to do something different. So in looking at that, we've realized it kind of extends our project a little bit longer before we go into implementation. And also, then we want to engage stakeholders as we develop these materials before we launch, right? So this is all really sensitive to us as it is sensitive to you. I mean, we're looking to give money out. We want to stabilize the field. So anyway, if you see the range of months, it looks like anywhere from 28 to 40 months would be for each cycle. But I will say cycle 1 was selected, and it represents all treatment. outpatient and residential embedded services. That receives 60% of state aid money. It turns out that's like doing 2 cycles in one. So we have extended. So right now this is what our timeline looks like, but I will say it could shift as we're looking into those different aspects. Okay, so let's do a little breakdown of what those services are, right? So cycle 1A was specifically outpatient, and cycle 1B was specifically, your inpatient residential bedded services. Cycle 2 is housing, treatment support, and harm reduction, which right now is captured under treatment support, but it deserves being called out because it's newer providers, and so in looking at that for cycle 2, it has its own focus. And then in cycle 3 is prevention, recovery, and gambling. So one of the first things that was done in December of 2023, and actually it was extended for the full month into January of 2024, was a voluntary survey that was administered to OASAS-funded providers of net deficit financing experiences, thus NDF, because as I already said, it has to be an acronym. Okay. So what you can see here is, a number of providers represented by, in the bar chart, the number of programs that they responded in their surveys. That's what the chart is showing. But we outreach to 344 providers, and 144 completed. And, in the standards of sending out a survey, a 42% response rate isn't bad. But I will say we did extensive research, and it was, Third Horizon Strategies really they reached out to anyone who even opened the survey and might not have completed it to find out if you have completed it. They really wanted to, I thought they did this really wonderful customer service to really try to help folks if they were having any difficulties in completing it. There was only one person from each provider that was allowed to be the respondent. So sometimes they saw 2 and they were able to clarify who that main person would be, and then they extended it, and we sent out numerous emails to try to get a more robust response. And then there was also a second survey that was sent out to the non-funded OASAS certified programs, so we could learn more from them on how did they get funding to start their program, and sort of how are they utilizing the operating budget, what are their revenues, and so forth. And this is all for cycle 1A and B. Okay. So let's take a look at the responses. Although we were at 42%, what is good is that when we take a look at the 1A survey, we have a good representation across the state of the respondents. And just note that the smaller circle means that provider had 1 to 3 programs. That there was 1 to 3 providers, 1 to 5 providers, or 5 to 9. So that's what that distribution means. And then you can see the distribution between the respondents in the types of programs. More importantly, in diving into the actual responses themselves, we highlight here some of the strengths that the survey respondents noted and challenges, and some anticipated transition obstacles. So the strengths of NDF was the ability to serve all individuals, offset costs for services not adequately reimbursed, fund care for individuals not covered otherwise, and then for challenges, payment structure does not cover cost of services, administrative complexities and burden, compliance or reporting challenges, and then under anticipated transition obstacles, risk for a variation in funding, concern for any added administrative burden, and then under other, the highest thing under other, because you could type in your thoughts there, change could lead to loss of funding. So obviously that is a concern for everyone. So there were two focus groups convened by THS for the OASAS funded providers that fell into cycle 1A. And THS divided the providers into a group, the first group that received a large amount of Medicaid, and the other group that received a large amount of NDF, right? And so the providers also were selected by if they were large, medium, small, how they had responded to the survey, which indicated engagement into this process. We also looked at, they were similar services, a similar revenue. That's why they were broken up into those two buckets, if you will. And then they were met with on, in March and April of 2024. And some of the things that were, commented on was that currently NDF is disjointed, especially when you're dealing with the different funding sources that have, different terms and conditions for those different funding streams. Providers are, struggling with administrative burdens and multiple layers of reporting to different state agencies and different county governments involved in distributing those funds or third-party reimbursement. There was inconsistent state aid administration. And this was especially, which is noted at the bottom, especially with contracts from more than one county or contracts with counties with the OASAS. So there was such a difference. And so navigating all of that. NDF likened to a capped grant award, just also I think reflecting not covering all expenses, right? The deficit not all covered. Transition from existing NDF that folks in these groups said should be considered is, the actual costs, improved uncompensated care coverage, incentivized efficiency, organizational health and provider stability, and also recommended that the transition should be incremental and phased in over multiple years. We agree. Okay. So let's take a look at cycle 1B. For, again, this is the residential, inpatient bedded programs. We did have a good distribution across the state again. There were, 63 respondents, and they broke up what types of programs. So that's sort of the distribution of who responded. And then what we can take a look at is very similar feedback, slight differences, and I think they really make sense because of the program. So NDF strengths: offsets costs for services not adequately reimbursed, ability to serve all individuals, funds care for individuals not covered otherwise. And here's the new one: the advanced payment approach. Obviously, I think it is more important for those bedded programs, especially if they don't have a Medicaid revenue source, right, where the advance is really important. Challenges: payment structure does not cover the cost of services, compliance or reporting challenges, administratively complex and burdensome. And then anticipated transitional obstacles, again, absolutely the same. Risk for variation in funding, if there would be more administrative burden, and other, and under other, they had mentioned limited funding from other sources, and also may not be able to provide services to non-Medicaid or commercial insurance patients. But they actually couldn't do that to be an OASAS funded provider, but we get the point that is being made. Okay. So, and the 1B focus group met in June of 2024, and also shared some, important points to consider. NDF doesn't fully cover operating costs, especially for non-Medicaid covered services. Obviously room and board is not covered in some of the Medicaid rates, and also, for other bedded programs. Also rely on NDF to cover, critical shortfalls in Medicaid or actual costs. This is consistent with the outpatient group. Administratively burdensome reporting, especially between multi-site programs offering multi-levels of care. And this is referring to the CFR. And although we're working on a different financing model, I don't know if I can take on redoing CFR, but we will take what you're saying into consideration and not try to make it any more burdensome. And no, we're hearing you. I don't want to make light, but we're hearing you. Does not incentivize innovation or capacity building efforts. And transition from existing NDF should consider more transparent and uniform methodology, incentivize efficiency and quality, and take into consideration philanthropic efforts. And the transition should be incremental. Again, we agree. So recently, THS met with housing. There were 11 providers in this focus group. Did I say how many providers were in the other group? There were 23 in the first group, in the 1B that I just covered. Okay, so housing had 11 providers. And we, just to level set also, for OASAS, we don't build housing stock. We provide, subsidies and wraparound service funding, right, for, rental units that are scatter site or supportive living, right. But what was shared in this group is that there's an inadequate fair market rates. So although we provide fair market rate for the subsidy, just in general, there's commentary was about that it isn't fair, and due to regional rental cost differences and available units near services, transportation, etc. The budgeting is a base level funding process and doesn't consider inflationary costs or unexpected costs, and that's true. I mean, we have the state aid ask process, but we understand what they're driving at. Unoccupied housing and turnover reduces revenue, which puts pressure on budgets. And just again to share, so state aid pays whether the housing unit is full or not full, but obviously when you have a client in the housing, you also have access to revenue from other social funding sources. NDF doesn't consider additional funding needs to support infrastructure and stability. Suggest OASAS explore other scatter site models and financing for best practice. Absolutely. OASAS's broader definition of homelessness, including at risk, is helpful to providing services to those in need. Good plug for a positive, and we will not change that. Okay, we also, I say we, again, these were all THS facilitated meetings. OASAS was not, present. I don't think we would hinder you from sharing, but we certainly didn't want to hinder sharing. We wanted THS to be that objective, component, and so there were 20 providers, and treatment support covers peer engagement, family support, non-medical transportation, as well as some harm reduction services, dual diagnosis coordinator, all of those treatment support services. And so some of the points here, NDF is, administratively burdensome and costly. New payment models should ensure more streamlined, less burdensome process. And the focus on this was more about CFR, but also interestingly, that the timing of when they have to pay an auditor to do their CPA review or their auditing review, they also extend that to having that same person put the information into the CFR. Where I don't know if all programs do that, because certainly those that are doing billing and claiming probably have a more robust fiscal staff. So that's an interesting component to understand, and we're glad they shared that. OASAS fiduciary oversight does not consider the level of investment against other funders. This is an interesting point also, because the point was made, if OASAS represents 25% of a provider's operating budget, but their terms and conditions require a lot more work. And totally understand, and we will definitely take a look at that, but also just share, and I know that you guys know this, is we too suffer the same thing, right? We have terms and conditions of federal dollars, terms and conditions of OGS, terms and conditions of OSC, and those get passed on because we need data information to be able to support upon audit, right? So it's a balance. And so, but we hear you, streamlining is always important. We will look for that. Fiscal review thresholds haven't kept up with increasing costs. And I believe they're referring to the administrative and fiscal requirements for OASAS-funded providers, manual, where, it used to be $5,000 or $10,000 requirement to get OASAS approval to spend, but you require 3 quotes, and that's just sort of good gap, procurement. But we'll definitely look at that. So appreciate. Allow organizations to retain surplus funds for capacity building. Again, that capacity building. So we'd like to take a look at what other data and research has been going on. So a number of years of Medicaid billing data has been reviewed. All OASAS payment codes that receive Medicaid, the number of services for each code by year, number of patients served by code by year, and then aggregating the amount of Medicaid paid, taking a look at that, and then also cross-referencing with CFR reported data, which, as I believe most of you know, or all of you know, Consolidated Fiscal Reporting System is a standardized reporting method accepted by 6 state agencies, and the data completed by service providers are those providers that receive OASAS funding, operate OASAS programs, or are authorized to operate through certificate. So all of them are reporting. We also, the client data system, the online reporting system that tracks SUD patient admissions and discharge, the CDS monthly data reports, and those are all compiled and cross-referenced, looking at the integrity of data, the reliability of data, and also helping us understand what other data might we need if we were to think about a different financing model, right? THS is also engaged in discussing with a number of academic settings on research that's going on value-based payment models, or looking at also quality measures, academic settings that are engaging with providers. We have such work that's going on with NYU, and so the meetings were held with those providers. Also meetings with the Behavioral Health Care Coordinators Network, meetings with representation from provider associations, and then there were 4 structured other state interviews with the other SSAs, and then literature reviews of over 10 different states. And from looking at those different states' information, there were a number of different types of models out there for how other states are providing, their state aid and their substance use block grants. Some of them were doing fee-for-service, Medicaid rate matching. Some of them were actually not. Obviously, they're not doing advances. They're having providers fill out vouchers. And some are automated systems, some are paper, and then those are reviewed and eventually paid based on uniform rates. Some states have hired an intermediary, which also takes up some of their state aid and SU block grant, to manage an uncompensated care pool, where again there's eligibility requirements that have to be shown that were met for those individuals to be paid for those services as uncompensated. And then state aid grants with outcomes and utilization measures. So those are some of the different types of funding models that have been used in other states. And then also THS did and hired outside legal review to review our New York State regulations on how we are making state aid available, and also on all the federal regulations around how SUBG can be paid, because it is essentially meant to be a reimbursement based. And so that entire review obviously took a great deal of time, but it was well worth it so that we could make the most informed decision as we move forward. So keeping in mind that state aid is a capped allocation in our budget, right? So we'll never be able to pay all costs. But OASAS seeks to distribute that state aid in a more fair and equitable modern method that will support this, providing services to the vulnerable population across our continuum of care. But there's essential questions. How do you continue to support services for uninsured, underinsured, indigent populations? And how do you develop and equitably, distribute the annual appropriated resources into a new funding model? Easy. No. They gave me such an easy job. I'm so excited. Okay, here we go. Suspense. We got our ideas from the surveys, from the stakeholder engagements. I mean, yeah, it aligns very much in things that some of it we knew, some of it we didn't. This has been a great process. Uncompensated care pool, pay for every visit with no payer source or an inadequate payer source, but there has to be integrity with that data, right? We also need to ensure that eligible patients are getting enrolled into Medicaid and that we're seeking to get payment from commercial insurances, right? So how do we do that? We don't collect that data yet, right? That's not by payer source, by patient. Discharge, payer source, but not by payer by visit, right? No. There is a schedule for OMH, but I don't know if it's detailed enough for me. No, but no, you're right. Thank you. No, this is great. Okay, another funding potential framework, right, that we heard about, that we're trying to work in, is support for programs, funding for the infrastructure, reporting for increasing provider capabilities, and to take into account individual circumstances that might result into a loss, right? Standardize that, make it fair, equitable. We very much agree. And also, third, social drivers of health, to ensure that services to the underserved that usually result in high needs, complexities, higher costs, that providers are able to provide because we're providing funding, right? And so we completely agree that these are the frameworks that have been outlined from engagement. How to do it is not easy, right? And how to do it across the number of different programs. So looking at cycle 1 first, which is, our 60%, that's what we're taking a look at, right? Lots of groundwork has been covered and reviewed and analyzed that I'm sharing with you. We've worked with stakeholders, we've had other town halls. We're meeting here at your inaugural event, and thank you for asking us to be here and share this information with you. But we're beginning that tough work of mapping out what some of these frameworks might look like, and recognizing that we don't have the data to actually do some runs. So now we have to look at, well, how would we get that, and how long would that take, and how do we check integrity, and how do we make sure, there's a lot, right? So a lot of work is happening. It's an iterative process, so please note this one. We will never flip the switch from historical budgets to new. Bye-bye. No, that's not going to happen, right? We're in this together. We want to sustain service delivery. It will be iterative. It'll be percentages of like new funding, small percentage, historical budget, big percentage, and just moving along, and also looking at things the whole time as we go through. But also still more stakeholder engagement to come, because we still need a lot more input as we start looking at these.
I'll say something more on the Article 31 side, where I have more experience than on the H20 side. So, and then I'm going to ask maybe a naive question on the other side. I think from the net deficit funding, where we get, it's very hard to really factor it into the budget in a meaningful way, because we never really know what the true numerator is. And although we've gotten better over the years at understanding what our ultimate number may be, we don't find out until months into the year. And so we have projections and everything else. So you're generally 6 months into your fiscal year before you get your final dollar amount, which I can imagine if you've been working off of a a forwarded funding amount in the past, that would be a really difficult transition. In talking with other OASAS providers and kind of talking about getting involved in the field and hearing about the fiscal modeling, a lot of what we had heard was that a lot of the fee-for-service would sort of balance the pool or anything else in the future. I was trying to figure out in the future modeling, I understand where some of the progression on the deficit funding goes. Is there also the assumption that there's going to be some rate reform that accompanies it that would balance maybe some changes to the deficit funding model?
Thank you for the question. It's a good question. We have put $37 million state share into Medicaid rates from the BHET dollars, and I know OMH has too. We absolutely want to continue. That helps those that have medicated services, right? We understand that part, but that is definitely part of what we'll be advocating for, and does put in. The THS is also taking a look at, wish I could talk, right? That was a little, but THS is also taking a look at where is New York as far as providing Medicaid rates, right? And from an outpatient standpoint, our APGs are pretty strong in comparison across the United States. Bedded services, there could be a definite case to be made to make some more investments, and we're working on that as well. So that, I'm so glad you asked that question, so I would be able to make that point. Again, it is an allocated finite amount of money, so we're looking to distribute that in a fair and equitable way. So we won't be able to hit all marks, but if we're hitting the most important things and being able to reimburse providers for the things that hit your pocketbook the most, we're hoping that makes the biggest difference. Any other questions?
I have a question, I joined this group out of conscious ignorance. I have a company that works in healthcare, and we provide a tool that improves patient communication. We doubled colorectal cancer screening in the Black community. It's been published in JAMA, and so we're in the addiction space. And we work in Pennsylvania and Maryland, and we're finding out that we're getting reimbursed for our communication tool. We're getting a double-digit increase in entry rates and retention rates. And so I have people in New York State who run addiction centers who would like to use our tool, but finances are tight. And so I've gone through all the channels of opioid settlement funds, both in Washington, D.C. and here. But what is the fastest, probably most convenient way? What can I say to someone who has a recovery center that wants to use us? What's the channel? What would they follow? What would they do? Because what we want to do essentially is have them try the tool and use it so that eventually we get reimbursed for what we're providing. And so we want to give them an opportunity. And again, it's an evidence-based tool, but I don't know how to navigate this and make it ubiquitously available. Does that make sense?
It does. So I have a general answer in which the state, from a procurement standpoint, cannot favor any vendors, right? It all has to be done on a fair and transparent basis. What I can say is that, you have your model, your business model, you're engaging, in calling on prospective, business partners. And I think the question is, what is the process that each of those providers would have to go through to become approved as a Medicaid entity to be able to bill for that would stand in your way, right? So the OASAS wouldn't be able to help you with that. Anything else? I'm waiting for the Jeopardy song. Thank you very much. I really appreciate you all being